How are you doing, anesthesiologist? I'm always grateful for your hard work, day and night. Wie geht es Ihnen, Anästhesisten? Ich bin Ihnen immer dankbar für Ihre harte Arbeit, Tag und Nacht. Como estão, anestesiologistas? Estou sempre grato pelo vosso trabalho árduo, dia e noite. Welcome to our deep dive into the Post-Anesthesia Care Unit, or the PACU as we all know it. We're going to be exploring that absolutely critical transition period for our patients, where our vigilance, our knowledge, and our quick thinking are truly paramount. We'll cover all the essentials you need to confidently and safely manage patients from the very moment they leave the operating theater, right up until they're ready for discharge.
So here's the roadmap for our session today. We're kicking things off with the absolute fundamentals, the standards of care, and the most common, and frankly, scariest respiratory complication, upper airway obstruction. From there, we'll navigate through the complexities of hypoxemia, then tackle hemodynamic instability, both high and low blood pressure. After that, we'll broaden our scope to a range of systemic issues like renal function and neurological challenges. And to wrap it all up, we'll look at the all-important discharge criteria and some special considerations for the modern PACU. It's a packed agenda, I know, so let's jump right in.
All right, let's get started with part one. You know, before we can even begin to talk about troubleshooting complications, we have to be absolutely rock solid on the standards of care. These principles aren't just suggestions. They are the very foundation of everything we do in the PACU. They create the structured, safe environment that every single patient deserves as they recover from anesthesia.
These are the 5 core standards from the American Society of Anesthesiologists, and honestly, they're non-negotiable. It all starts with the universal principle that every patient receives appropriate care. Then, Standard 2, which is so crucial. The patient must be accompanied by a knowledgeable team member during that incredibly vulnerable transport phase. Standard 3 ensures that all-important seamless handover of information to the PACU nurse. Standard 4 is the what of our monitoring, those 5 pillars: oxygenation, ventilation, circulation, consciousness, and temperature. And finally, Standard V makes it clear that the ultimate responsibility for discharge rests with the physician. This is truly the bedrock of our practice.
So this table is where those broad standards become a practical, tangible checklist at the bedside. It's how we bring it all to life. You can see how it breaks down our assessment system by system. For respiratory, it's not just about saturation, it's about patency and rate too. For cardiovascular, routine heart rate and BP, of course. But look at neuromuscular. It's a specific requirement to assess function if neuromuscular blockers were used. We're going to come back to why that is so important in a moment. The rest covers all the essentials: mental status, temperature, pain, nausea. This is your real-world guide to applying those ASA standards to every single patient. And here's why that systematic approach is not just good practice, it's absolutely vital. Take a look at this number, 24%. It comes from a huge prospective study, and it found that nearly 1 in every 4 patients has some kind of complication in the PACU. Let that sink in for a moment. This isn't a rare occurrence, it's an everyday expectation. This single figure just hammers home the high-risk nature of this recovery phase and why our constant vigilance is so critical. It's a number well worth remembering.
And if we look a little closer at that 24%, here's how it breaks down. You can see that postoperative nausea and vomiting, or PONV, is the most frequent complaint at nearly 10%. But here's the key takeaway. While PONV is incredibly common and unpleasant for the patient, the complications that cause the most severe, life-threatening outcomes are respiratory and cardiovascular. The need for upper airway support comes in a close second at 6.8%, and hypotension is right behind it. So, while we absolutely manage PONV for our patients' comfort, our critical, life-saving focus has to be on breathing and circulation.
So, this is a really crucial point. Patient safety doesn't start when they hit the PACU bay. It starts the second they leave the operating theater. That journey is a period of significant risk. In fact, a major observational study found that the single most important predictor of a patient arriving in the PACU with hypoxemia was, quite simply, breathing room air during transport. It's such a simple intervention, but it has a profound impact. This is why providing supplemental oxygen during transport shouldn't be an optional extra, it has to be our standard of care.
Now let's dive into our first major challenge, and as we saw, the second most common complication overall: upper airway obstruction. The number one cause is elegantly simple and yet profoundly dangerous. It's a loss of pharyngeal muscle tone. As the residual effects of our anesthetic agents, our opioids, and our neuromuscular blockers are still lingering, the muscles that hold the airway open just relax. They become flaccid, and this leads to the tongue and soft palate falling back, obstructing airflow. It's a purely mechanical problem.
This slide illustrates an absolutely key clinical pearl
in preventing that obstruction from residual paralysis. For years and years, the 5-second head lift was the gold standard, wasn't it? Well, it turns out it's remarkably insensitive. A patient can actually perform a head lift with a train of 4 or TOF ratio as low as 0.6. But we know that normal pharyngeal function, the ability to protect their own airway, doesn't return until that ratio is above 0.9. A much more reliable clinical test is asking an awake patient to bite down firmly on a tongue depressor. If they can hold it against you trying to pull it out, that correlates with a TOF ratio of about 0.85, which gives us much greater confidence that their airway is protected.
And when you do suspect residual neuromuscular blockade, it's so important to think about what else might be contributing. This table provides a fantastic framework for that. Under drugs, remember that our inhaled anesthetics and certain antibiotics can actually potentiate the block. Metabolic disturbances are huge culprits too. Hypothermia, a bit of respiratory acidosis, and electrolyte imbalances like hypermagnesemia can all prolong muscle weakness. And of course, we have to consider patient-specific factors like renal or hepatic failure. It's rarely just one thing. You always have to consider the bigger picture.
Laryngospasm. It's a terrifying event for everyone in the room, a forceful tonic closure of the vocal cords. Your response has to be immediate, calm, and stepwise. First things first, remove the offending stimulus. That usually means suctioning any secretions or blood from the pharynx. Next, apply a firm jaw thrust and positive pressure with a face mask. You can crank up the CPAP to 40 centimeters of water to try and stent those cords open. If that fails, do not hesitate. Administer a small dose of succinylcholine intravenously. And if, in the very rare case that doesn't work, you must be prepared to proceed immediately to a full induction and intubation.
Beyond that loss of muscle tone and laryngospasm, we have to consider structural causes. Edema or a developing hematoma, particularly after neck surgery like a carotid endarterectomy or a thyroidectomy, can physically compress the airway from the outside. A really useful tool before extubating a high-risk patient is the cuff leak test. And then there's the unique challenge of the patient with obstructive sleep apnea. These patients are incredibly sensitive to the respiratory depressant effects of opioids. Key management strategies for them are keeping them in a semi-upright position, using a multimodal opioid-sparing pain regimen, and getting them on their home CPAP as early as possible in the PACU.
Right, so we've moved from A for airway, let's now go to B for breathing. Postoperative hypoxemia is an incredibly common and serious challenge. Understanding its various causes and having a really systematic approach to diagnosis and management is an absolute core skill for anyone working in the PACU.
Okay, so the patient's oxygen saturation drops. The alarm is going off. This table is your mental model for the differential diagnosis. The most common culprits by far fall under ventilation/perfusion mismatch, like simple atelectasis. Next, you have to consider the gas in the alveoli. Is the patient hypoventilating from residual anesthetics or opioids? We also have to think about pulmonary edema from various causes, which we'll get into. And finally, think systemically. Is the patient's oxygen consumption massively increased from shivering? Could they be septic? Could this be a pulmonary embolus? Using this framework ensures you consider all the possibilities and don't miss a critical diagnosis.
It's really important to be able to distinguish between these two specific causes of non-cardiogenic pulmonary edema because they can look similar initially. Post-obstructive pulmonary edema, or NPPE, is a mechanical problem. A strong patient inspires forcefully against a closed glottis, creating this immense negative intrathoracic pressure that literally sucks fluid into the lungs. In contrast, transfusion-related acute lung injury, or TRALI, is an immune-mediated process. It's caused by antibodies in the donated blood product that activate the recipient's neutrophils in their lungs. The triggers are totally different, so getting the diagnosis right really matters. For a definitive diagnosis of TRALI, and certainly for your exams, you must know these formal criteria. First, the timing. It has to be an acute onset, during or within 6 hours of a transfusion. Second, there has to be objective evidence of hypoxemia, like a PaO2/FiO2 ratio of 300 or less. Third, you need radiographic evidence, the classic bilateral infiltrates on a chest film. And critically, number 4, you must have excluded a cardiac cause for the edema. These 4 points are absolutely essential.
This quote highlights such a fundamental concept, one that we can never, ever forget. The pulse oximeter is our standard tool for detecting hypoxemia, yes, but it is a terrible tool for detecting hypoventilation. This is especially true when a patient is receiving supplemental oxygen. The oxygen reservoir in their lungs can keep their saturations reassuringly high for minutes, even if they are barely breathing at all. The saturation will only plummet once that reservoir is completely depleted.
A pulse oximeter is never a substitute for actually looking at your patient and observing their respiratory rate, their pattern, and their effort. For the patient who is failing simple oxygen therapy, non-invasive positive pressure ventilation, or NIT-PV, can be an invaluable bridge to recovery. This protocol outlines a really safe and effective way to get started. First, you have to select the right patient. They need to be cooperative, able to protect their airway, and have a low risk of aspiration. Then, position them sitting up. A good mask fit is absolutely essential, and it's so important to talk them through the procedure to reduce their anxiety. You always start with low pressures and titrate slowly. Use CPAP or PEEP to improve oxygenation and pressure support to ensure they're getting adequate tidal volumes. And of course, careful monitoring is key throughout.
All right, let's move on to C for circulation. Hemodynamic instability is extremely common in the PACU, and it's associated with significant morbidity. Both hypertension and hypotension demand a structured, rapid response from us to identify and treat whatever the underlying cause may be.
When you see a high blood pressure reading on the monitor, your first instinct shouldn't be to immediately reach for an antihypertensive drug. Instead, you have to mentally work through this differential diagnosis. The most common causes by far are simple physiologic stressors: pain, agitation, or shivering. Always check the basics. Is the patient hypoxic or hypertapnic? Then consider their volume status. Could they be hypervolemic, or is it as simple as a full bladder causing a sympathetic surge? Only after you've ruled out all of these reversible causes should you start to consider a primary pharmacologic treatment.
Now for the opposite and often much more urgent problem. A hypotensive patient in the PACU is a true emergency until you prove otherwise. Your assessment has to be rapid, structured, and calm. So what is your immediate differential diagnosis?
This slide provides the perfect framework for that differential. We classify shock into 4 main types, and it's a great way to organize your thoughts in a crisis. First, and by far the most common postoperatively, is hypovolemic shock, a problem of decreased preload, think bleeding or third spacing. Second is distributive shock, a problem of massive vasodilation or decreased afterload, like we see in sepsis or anaphylaxis. Third is cardiogenic shock, a pure pump failure problem. And fourth is obstructive shock, where something is physically obstructing blood flow, like a massive PE or cardiac tamponade. Identifying the correct category is the absolute key to life-saving management.
Within that broad hemodynamic assessment, we have these high-stakes cardiac events that we need to be ready for. For myocardial ischemia, the goal is always to optimize the oxygen supply-demand balance for the heart. For tachycardia, the algorithm is beautifully simple. Are they stable or unstable? Unstable means synchronized cardioversion, right now. Bradycardia is very often iatrogenic. Think about the drugs you've given recently. And with ventricular arrhythmias, you should always have a high index of suspicion for QT prolongation from common drugs like ondansetron. And remember, the immediate treatment for Desade's de pointes is magnesium. In all of these scenarios, rapid recognition and sticking to established ACLS protocols is absolutely paramount.
Excellent. We've covered the ABCs in detail. Now let's broaden our focus a bit to some of the other systemic issues that frequently pop up in the PACU. These challenges involving the renal, thermal, and neurological systems can really have a significant impact on a patient's recovery, so let's start with the kidneys.
When the nurse tells you that the patient's urine output is dropped off, this is your mental framework. Postoperative oliguria is neatly classified into 3 categories. Prerenal is the most common, caused by inadequate perfusion to the kidneys, usually from hypovolemia. Renal or intrinsic causes involve direct damage to the kidney itself, and postrenal causes are due to a simple obstruction downstream. Your first thought should always be prerenal, hypovolemia, but please never ever forget to do the simple thing first. Check the urinary catheter for any kinks or blockages.
This chart demonstrates a very specific cause of prerenal failure that is critical to consider after major abdominal surgery, intra-abdominal hypertension. It's really just a matter of physics. As the pressure inside the abdomen rises, it compresses the renal veins, which impedes blood flow and reduces kidney perfusion. And this effect is dose-dependent. Once that intra-abdominal pressure gets above about 15 millimeters of mercury, you start to see oliguria. By the time it reaches 30, anuria is common. This can rapidly progress to abdominal compartment syndrome, which is a true surgical emergency.
Let's move on to temperature. Postoperative hypothermia, which is defined as a core temperature below 36 degrees Celsius, is not just a matter of patient comfort. It has profound and really adverse physiological consequences. A cold patient is a coagulopathic patient. Hypothermia directly impairs platelet function, and it slows down all the enzymatic reactions of the coagulation cascade. It also slows drug metabolism, which can significantly prolong the effects of our neuromuscular blockers. Actively warming our patients isn't just nice, it's a critical safety intervention.
For PONV, which we know is the most common PACU complication, a multimodal approach is always best. This table shows some of our go-to agents, and notice how each one works via a different receptor pathway. Ondansetron is a workhorse first-line agent. Dexamethasone is fantastic for prophylaxis when given at induction. The key principle is this: if a patient has breakthrough nausea despite having received a drug from one class, your rescue antiemetic should always be from a different class, so you're targeting a different mechanism of action.
It is absolutely vital to be able to differentiate between these two very distinct neurological states. Postoperative delirium is characterized by a fluctuating course, and this is the key feature, inattention. It's most common in elderly patients, and it can persist for hours or even days. Its management focuses primarily on non-pharmacologic interventions. Emergence excitement, on the other hand, is an acute, very brief, and often hyperactive state, seen mainly in young children after volatile anesthetics. It's self-limiting, usually resolving completely within 10 minutes. Their management and prognosis could not be more different.
For the patient who simply doesn't wake up in a timely manner, a systematic approach is absolutely essential to avoid missing something important. First, check the absolute basics. Are the anesthetics actually turned off? Are their ABC stable? Next, check their core temperature. Severe hypothermia can certainly cause this. Then, perform a basic neurologic exam. After that, you need to specifically rule out residual drug effects. Check a train of 4 and consider reversal agents like naloxone or flumazenil. If you're still not getting a response, it's time for a metabolic screen. Check a blood glucose. And if all of these are unrevealing, you must escalate and consider an acute neurologic event, which means getting urgent brain imaging. And finally, we've arrived at part 5. We've managed our patient through that most critical initial phase. Now we turn our attention to the ultimate goal of PACU care, making sure that they are stable and safe enough to move to the next stage of their recovery, whether that's a hospital ward or even their own home.
To bring some much-needed objectivity to the discharge decision, we use scoring systems. The Altrade score is the absolute classic tool. It assesses 5 key variables: activity, breathing, circulation, consciousness, and oxygen saturation. So, a patient who can move all 4 limbs, breathe deeply and coughs, has a blood pressure within 20% of their baseline, is fully awake, and maintains a saturation above 92% on room air would score perfect 10. Typically, a score of 9 or 10 is required for a patient to be considered safe for discharge from the PACU.
You know, the modern PACU is not a one-size-fits-all unit anymore. We're managing increasingly specialized and complex patient populations. For craniotomy patients, for example, we have to maintain incredibly strict blood pressure control and meticulously avoid anything that could raise their intracranial pressure. We also see more subtle complications, like corneal abrasions, the most common eye injury after anesthesia. And on a systems level, we have to acknowledge the expanding role of the PACU in managing ICU overflow. This requires our units to be staffed with nurses who have critical care competencies to maintain safe nurse-to-patient ratios for these very sick patients.
And that brings us to the end of our refresher course. We've covered the standards, the common complications, and the really evolving role of post-anesthesia care. The crucial takeaway, I think, is that the PACU is an incredibly dynamic, high-stakes environment. It's no longer just a simple recovery room. In many ways, it's becoming a critical care hub that is constantly adapting to the modern healthcare system. And as its role continues to expand, our unwavering commitment to systematic assessment and constant vigilance is what will continue to ensure the very best and safest outcomes for our patients. Thank you so much for your attention.